every day. And we know prevention saves lives. This is a slide that I did actually at the summit, and I was really surprised at how many mammograms we do every year and how many colonoscopies we do every year, and what the death rate is related to that, and yet what the death rate is with heart attacks. And we all know these numbers, and so we know prevention saves lives. We know it does. Again, we're here today with the University of Best Practices and how we're going to increase and get to 0 heart attacks, which I love, and I'm just grateful to be a part of it. I would like to introduce to you, though, a guest that I brought, and his name is Ken, because unfortunately, most of my stories are people who have not survived. And I would love for Ken to just share his story and his journey. Do you want the microphone? You want to do it from over there?
I think my voice carries okay. I mean, whatever you think is best.
It's a little easier for others to hear you
Okay,
if you
very
use the
good.
mic.
Okay. I like to be a little more informal. This is a pretty sobering experience for the average guy to be sitting in here, but with such an august group of really accomplished people and intelligent people. And the passion for what I see here. I've become a real student of all of this since June. And the purpose of me being here is just to talk about my story, and that I am so grateful for the calcium score test because I believe it saved my life. I'll do this, I'll talk a little bit about my past and my background quickly, my calcium score test and the medical actions that we subsequently did after that, and then the major life changes that I've made since I've gotten the scores. Anyway, bottom line is I'm a director with a major global engineering company and worked a lot. And the last year and a half or so, I'd been traveling every week to work on a troubled project. And 2.5 years before that, I'd worked on major projects over in the Middle East. And throughout the history of my life, going back to my early Air Force days, my flight physicals and stuff, I used to get them, and I have had an issue with high blood pressure, but we had always had it, quote, under control. But over the years, I've led a little bit of a sedentary life, could have done more exercise, and it's like always tomorrow, always tomorrow. Had physicals every year and a half, and those physicals were, basic. I had the EKGs, blood tests, my cholesterol scores were always very good, and asymptomatic, not feeling anything. And then even my most recent physical, prior to, it was about a year ago, they did echocardiograms, ultrasounds on my carotid, my kidneys, and all the overall scores are within acceptable ranges, nothing negative. My diet wasn't optimal, and I knew that. But there was concern with my high blood pressure, so my primary care physician referred me to a cardiologist. So I went to the cardiologist, and after him taking my history and doing an exam, he said, we should get you a calcium score test. And so I went and got the calcium score test on June 13th of this year. And my score was bad. So within a week, pardon me?
What was the number?
Over 8,000.
Whoa.
In fact, I was told, this is what spooks me. I mean, this is why this is so sobering. I mean, people say, I've never heard of such a score.
I have a family member like that.
Okay. God, I'm not the only guy then.
Yeah, and you look great, right? So
Well,
you can't look at a person and know.
Anyway, and I was thinking, God, is this a false positive? I don't know if it is or not, but it was high. And so within a week, I had a heart cath procedure, and they decided, they went and did an exploratory, and then it's okay, well, let's not do anything right now, let's check, because you might need to have a bypass. So we consulted, and within 3 weeks after that, I was having in my second heart cath, and I had 4 stents put in 2 arteries, 3 in my left anterior descending and 1 in my circumflex. And the great thing is, though, in Colorado, they don't require a doctor's order to get the test. The test costs only run between $50 and $100, and you can just call and go in. Insurance doesn't cover it, though; it's not a covered item. And one of the sad things is that my friends that I've gotten about 10, 12 people now to get calcium score tests. Some have been dissuaded did not get one, that it wasn't necessary, they weren't in the proper risk factors. But anyway, since then, since the June 13th, I immediately went on a plant-based diet, and I started an active physical training program where I'm doing cardio exercise at least 6 days a week and lifting weights a couple of times a week. So far, I've lost 57 pounds since June.
Wow.
And I was in an active, thank you. Always feels good to hear that, man. The pants feel better. They're not like tourniquets wrapping around your waist. And I went through a cardio rehab program for 2 months through my cardiology group that I was working with. Wonderful staff, wonderful nurses. And in between the classes, that was 3 days a week, I was still doing my own thing, so I'd always get my 6 days. And then so between the exercise, the major change in diet, and the medicine regimen that I'm on, I'm feeling terrific. I have never felt this good. I don't know how long it's been since I felt this good. I did not have any event, so thank God for the calcium score test that I can come here and say that I didn't have any issues, and that I think I'm doing my very best to turn this thing around, and I believe that this is my new way of life. Even though I heard some stats tonight that are kind of with what was it, lifestyle changes or?
Success rate and lifestyle change.
Yeah, it's less than 1%. I don't think I'm going to go there. I'll never want to go through this again. So anyway, lost 57 pounds, lost 6 to 8 inches in my waist, and I think I've gained I've increased my IQ by about 100 points. Well, that might be a little bit of an embellishment. But the bottom line is that I believe the calcium score test and my cardiologist saved my life in general, have given me back a great life. I've reduced a lot of my stress because the things that I was doing were very stressful. Blood pressure's under control, weights, I still want to lose another 15, 20 pounds. But anyway, I just can't say enough that I believe the calcium score test should be as prominent in our testing regimens as my wife actually runs the mammography department at a major hospital in Denver. So I hear her stories all the time and how they're finding things, and, well, it's a side story. Younger and younger women all the time, and she comes home so sad. But that, and then the colonoscopies, I can't believe that this isn't part of the average regimen to let people get the information as soon as possible. I think that's all I have. Anyway, thank you. Thank you for letting me talk. And by the way,
Thanks,
Stephen,
Ken.
Cal, they whipped Boulder. I'm from Denver, and they whipped CU pretty good last year.
It happens every 10 years.
Ken, thank you so much for sharing your story and for flying out here today. Feel free to talk with him when we're doing our little socializing. I also wanted to introduce Jim Dury from Life Saving Images, who's a guest with No More Broken Hearts, and my very, very dear friend Safi over there, who's with Apple and was Dean's mentor. So just you guys, thank you so much for letting us be here. Really, really appreciate it.
So the reason we are here today is because one of the original members of the RightCare family, Dr. Scott Flynn, who had been my co-chair in San Diego when we first started and was willing to explore how do we hit those targets. He had a different attitude than your average person because he'd done 2 tours with the Navy SEALs. And he was like, of course we can get this done. Fast forward many years later, and he's lost a few buddies to heart attacks, I'm pretty sure. And he's in a new position with Blue Shield where, after we published in Health Affairs that by simply controlling LDL, blood pressure, and blood sugar to the NCQA modest targets, we were able to reduce acute myocardial infarction hospitalizations by 24% in 4 years, sustained at 22% at 6 years, with an estimated savings by RAND of $935 million if we'd spread it statewide, and 22,000 fewer heart attacks since we started our work in San Diego. So when Scott Flynn got that article, he boldly marched to somebody who could do something about it and said, let's start a new one in the Bay Area. Let's get this going in the next biggest metro area in the state that doesn't have coverage by the RightCare initiative. And what excited me about bringing it to Silicon Valley was the critical mass of amazing people I know here already, and the attitude. I have this Apple Watch which teaches me my heart rate, and biofeedback has helped me immensely. And it's just the tip of the iceberg. So we're so happy that we have Apple here with us today, because what we want to do in Silicon Valley is build on, look, if we could do 24% in the sleepy little happy town of San Diego, I think we could easily do 50% in Silicon Valley. And I am not kidding, because people don't pay attention to the numbers. And one of the key ways I think we can do it is by doing proactive scanning. So we know who the vulnerable are to get them into treatment. And some will say, well, we don't really know that once we know your score, we can do anything about it. Well, I'll tell you, I am really damn happy that I know what my score is and that I have to change my life. And I have changed my life. I, like Ken, have gone to a plant-centric diet and have really, I monitor my blood pressure so closely because people like David Marin, the head of preventive cardiology, have taught me to do so. So thank you, David, for being here and for leading the charge.
Okay, thank you. I'll just stand up here for a moment. Now we get to the meat of the program, because opposing sides here, stories are really what drive a lot of us, but at the end of the day, to make important policy decisions, we need evidence. In people maybe who are crying because they know someone, and almost all of us know someone who's had a terrible event that could have been prevented. On my right is Matt Budoff, who will review the evidence to support the use of coronary calcium scanning. Matt is one of the foremost experts in the world on coronary calcium scanning. We're lucky to have him here tonight. And on my left is Doug Owens, the incoming chair of the U.S. Preventive Services Task Force. And as you may know, the U.S. Preventive Services Task Force just presented their report on coronary calcium scanning, which said there's not yet enough evidence to recommend it for or against. So it'll be very interesting to hear the same evidence interpreted, I suppose, in different ways. Hattie asked me to say something about how we use coronary calcium scanning at Stanford in the Preventive Cardiology Clinic. Neil, this is the same clinic where we saw patients a few decades ago. But we have this new test, and we use it a lot. And the guidelines are starting to catch up with the way we use it. The way we use it, and again, this is an anecdote, but there are a lot of times when patients who clearly need to be on a statin present that they're at high risk, and they come into the clinic and they say, no statin. And I say, okay, but if you knew you had coronary disease, if you knew you had atherosclerosis, would you consider being on a statin? Then they say yes, and I get a test. And frequently, we review the pictures, and they say, I'll take the highest dose. And then there are others who are in the same situation. They have zero calcium. And I say, okay, it's reasonable to withhold a statin, and let's repeat the scan in a few years. And then there's another category of patient who has a strong family history and has very low risk. When you use the ASCVD risk calculator, it's less than 5%, often less, even less than 3%. They have a really compelling story. Maybe they have a high Lp(a). And we get a scan in a young person, I mean less than 40 years old, they have calcium, which any amount of calcium at a young age, they're way over the 90th percentile. And it's somebody that we usually start on a statin in addition to aggressive lifestyle intervention. So that's basically the way we use the test. And then we get referred a lot of patients who have very high scores and they say, what do I have to do? My cardiologist said I should have an angiogram. Do I need an angiogram? I have no symptoms. Do I need a stress test? Do I need an angiogram? What do I need to do? And that's the common scenario. Anyway, I don't want to waste any more time. I'll ask Matt to come up, and you can see the title of, or you could see the title of this presentation. As you'll learn, if you don't already know, there are new guidelines that have really advanced the use of coronary calcium. Matt?
Thank you, David. So it's really an honor to be here, and thank you, Heidi, for helping expedite things. It was at 3 airports.
So I was a travel agent today, in addition to the person who set up the room, because poor Matt's flight got completely messed up, and we had to engage UC Travel, and the cavalry arrived, and thank you, Bob Trine, for picking him up at the airport and getting him here in time to present the data. And just to save time, we're not going to read the bios to you, but we hope that you will notice that Dr. Budoff has over 800 published articles and 7 books, and he's the man, as David Merritt would say. He knows this topic cold and speaks internationally about this.
So just to put things in perspective, we heard a little bit about mammography and breast cancer earlier, and what you were talking about what your wife does is, and it's very important, and I'm trying not to minimize anything. This is actually from a preventive cardiologist that speaks. She speaks about women's health internationally as well, and this is the problem that we face. The numbers haven't changed much in the last few years, but about 400,000 women every year will die of cardiovascular disease, and about 40,000 women will die of breast cancer. So literally it's 10 to 1. Yet in any forum, when you ask women what's their number one health concern and what do they think they're going to die of, it's the opposite exactly. It's 10 to 1 that they're going to say breast cancer. So we've done a lousy job of putting this out there in a way that attracts the attention that breast cancer does, right? Angelina Jolie gets a arguably inappropriate bilateral mastectomy, and hundreds of thousands of women start to get mastectomies to prevent their risk of breast cancer. Totally unproven, but that's fine. But it's just one of these things where we can find these little things, and we could, U.S. Preventive Task Forces has, obviously, breast cancer is a major thing that mammography is recommended. Lung cancer has screening, and that's recommended. But the big gorilla in the room, heart disease, really doesn't have screening yet. So this is what we're supposed to use for our preventive screening. So cardiologists, primary care physicians are supposed to use this risk calculator. And we do, and we plug in whether they're male or female, how old the person is, if they're white or African American or Hispanic or Asian, and then plug in a couple of their cholesterol values, and yes, no for smoking and diabetes, and we get a risk estimate, and that's supposed to drive who gets statins and who doesn't. And this was recommended up until 2 weeks ago as the way to screen. That changed 2 weeks ago, I'll show you, but the problem, and this was validated up here in Northern California, 300,000 patients in red is the event rate that they expected based on the risk calculator. In blue is the actual event rate. So you can say, well, that's great. They're having many fewer events than they anticipated. The problem is these aren't necessarily treated patients. These are just patients out there, and so what we're doing is grossly overestimating cardiovascular risk to the tune of about 400%. So literally we're inflating people's risk and then putting them on statins and aspirin and other therapies, maybe doing further testing based on the risk calculator. And the problem is most of those patients, 3 out of 4 that get identified as high risk, are not high risk. They're low risk, and they will not have an event over the next 5 or 10 years. This is a 5-year model here. So we have a risk calculator that is as broken as it can get. There's nothing worse than this that I'm aware of in any field of medicine, where we overestimate risk by 400%. And thus the new cholesterol guidelines came out 2 weeks ago to try to address this and help us identify who might be better treated and where we can spend more of our resources on the people who have the plaque and less resources on those who do not. And that's the newest part of the guidelines. So to understand the coronary calcium score, we've talked about a little bit, but I just want people to understand that calcium is literally just the tip of the iceberg. And a friend of Jim Adams and mine, John Rumberger, came up with this analogy out of Mayo at the time, and he taught us that based on autopsy data and based on pathology, that calcified plaque represents about 20% of total plaque. But the math is solid. So when the Titanic's going downstream and it sees a big iceberg, it didn't say, let's send some divers below the surface of the water and see if there's any ice that could rip the hull. They knew that there was something bad below the surface of the water. And when we see calcified plaque, we know that there's fibrotic and lipid-rich soft plaque that can rupture, that can cause damage. And the bigger the iceberg, the bigger the problem. And the good news is, when there is no iceberg in the water, you don't have to worry about your ship sinking, because your risk of having a problem approaches 0%. And I'll show you some data. So what we call the power of 0. So it works both ways. We can identify people with a lot of plaque with a high score. We know that they have more than just the calcified plaque. They have all the plaque. And then we can also identify people who have no plaque at all. So a lot of this data came out of a study called MESA, the multi-ethnic study of atherosclerosis, about 7,000 people, ages 45 to 85, population-based, 51% women to represent the exact population, distributions of African American, Hispanic, Asian, and whites. And it doesn't matter what color of your skin, age, or gender you were. If your score was above 100, you were 10 times more likely to suffer a heart attack in just the next 3.5 years. Short-term risk, it was very high. And the good news is, if you had no coronary calcium, your risk approached to 0%. So
And that's heart attacks and stroke?
This was heart attack and death. I'll show you heart attacks and strokes in a moment. We used to not care about strokes, no offense, but in our risk calculator was coronary heart disease. The strokes just didn't work in there. I have a paper that addressed that specifically, and I know it's a very big issue with Hattie. So there's a lot of ways of potentially screening. So we looked at many of them, and everybody in the trial underwent many, many different tests. And the only test, and this is, I apologize, I know it's a little statistical thing, but the curve that's higher and to the left is the better predictor of future events. And all the other lines are superimposed, including a blue line somewhere in there, which is our Framingham risk estimate. So our Framingham risk estimate was right about 60% of the time. Not terrible, but a little better than a coin flip in MESA. But nothing really improved upon it. We tried C-reactive protein. We tried asking about their family history. We tried looking at endothelial function in the vascular bed. We tried looking at the carotid artery to see if that predicted heart attacks and strokes better, and that didn't work either. And this is cardiovascular disease, Hattie on the right, so that does include stroke. The only thing that robustly improved risk prediction was the coronary calcium score. So there's just one piece of evidence in a large multi-ethnic study. The US and our National Institute of Health invested about $100 million in this trial, and they concluded that coronary calcium scanning was the best predictor of future cardiovascular risk. Now, it's not the only study, there's many studies, but if you look at this, and this is a way that we think about it to say, how many people do I need to test to improve the outcomes or to identify a patient who's different than what I thought they would be? In other words, reclassify them. I thought they were high risk and they're really low risk. Or like Victoria's husband, I thought they were low risk, but they're really high risk. How many people do we need to test? And if we do something like C-reactive protein or ankle brachial index, we have to test dozens of people to reclassify one person. So that's not very cost effective. For coronary calcium, we reclassified 66% of people tested. So for every 3 people we tested, 2 of them moved either up or down. And it's not what you think. It's not that everybody had coronary calcium. It's that very few people have coronary calcium. So this is the intermediate risk in another big population-based study. And from the intermediate group, 1 out of 7 moved upward. In other words, 14% of people we thought were just intermediate risk and they were really high risk because they had a high calcium score. But 63%, 2 out of 3 people tested, had a score of 0 and were really low risk. And this reflects the overestimation of what we see in risk calculators. This is the same thing. We overestimated risk in 63%, or 2/3 of patients, we overestimated risk. So we tend to overestimate risk to find people who need treatment. And that's great because treatment works. The problem is there are side effects to treatment. Patients don't buy into it, so they discontinue treatment after some period of time, and they don't stay on the therapy. And then later in life, when they really need the treatment, they're like, I already took a statin for a few years. I don't want to do that anymore. And then they're now not wanting to take it when the actual time is right.
What's the age range on that, in that study?
So this trial was, this was a population-based study. So this was the Heinz Nicanor study. So this was pretty similar to MESA. This was 40 to 70, so a tiny bit younger. But there's 50 to 70 patient populations as well that have been studied. So it's mostly middle age, right? That's what we're targeting, what I call the age of atherosclerosis, which is 40 to 70. And we'll always know, and we take care of people who are the outliers as well. We see a 28-year-old who comes in with a heart attack, but those aren't the people we're trying to screen. We're not trying to go after the 1 in a million. We're trying to go after the common #1 cause of death in the United States. So I looked at 10-year outcomes in MESA because we tend to like these 10-year risk calculators, and this does include atherosclerotic cardiovascular disease. In other words, stroke is included, and stroke worked. I'm just blowing up one of the 4 boxes, but there were 4, I'll go back one sec, there were 4 boxes looking at, oh, that's actually the wrong, oh, that's sorry, I went forward, no, that's a different one, sorry. So white, Asian, black, and Hispanic, and then I'm just blowing up the white category. It used to be animated better, but I don't know what happened. But anyway, and what you can see is that red line represents what was our 7.5% high-risk cohort. And a calcium score of 0 out to 12 years stayed below that. The risk was never approached, no matter what their underlying risk factors were, never approached that 7.5% risk. In other words, they never qualified for therapy because they never had enough events to warrant therapy. And everybody whose score was above 100, and in some groups it's a little bit lower, but everybody whose score was above 100 qualified for therapy at 10 years. And if we draw a line up here at 10-year risk, we can see that they're way above the red line in this 100 to 300 group, and above 300 even higher. So I concluded that no matter what the age, gender, or ethnicity of the patient was, a calcium score of 100 represented a high 10-year risk and deserved more aggressive therapy. And the guidelines weren't written that way before this paper. Before this paper, they said, well, you don't have data on stroke. And that's what the U.S. Preventive Task Force has said. So this is data on stroke. And we have specific data on stroke as well from MESA with a few different publications. But this included stroke. They said, well, you don't have population-based 10-year data. This is 10-year data, true 10-year event rates. Not estimated 10-year event rates, but this is what happened to the patients over a decade. So we tried to address those. Now, this paper just got published, and it's a long-term follow-up of an interesting population. This is a patient, on average, age 50, but they went down to their late 30s. And you can see that no matter